and final. Welcome to our final 11th and final lecture of the series for this year, and we won't have any in December. So this would be the last lecture for the year, and then we will resume specialty lecture next year. I just want to go over the same housekeeping rules that we have before. So during the lecture, all the audiences will be muted, and if you have a question, please add that to your chat box, and Aisha, who's the moderator, will keep a track of that. And at the end of the presentation, we'll pose those questions to Dr. Freed. Also, I would request that you don't start a side conversation in the chat box, because that's distracting to the speaker, and just wait for the end of the lecture and then have the discussion, questions, whatever we have. We will have plenty of time for that. And also don't forget to fill in the survey that would be posted in the chat box. That really helps us to know how we can improve and what other topics that you're interested in that we can arrange lectures for. With that, I will introduce our speaker. First of all, Dr. Amanda Freed, thank you so much for joining us on a Sunday morning. I know we have a long weekend here. It's a Thanksgiving weekend, and I really appreciate you agreeing to give this lecture, and this is, it's great to have you. Dr. Freed is one of the newer member of our department here in Southern California, Kaiser Permanente, and we are extremely proud and happy to have her with us. And she's been here with over almost 2 years, right, Amanda?
Just over a year.
Just over a year.
Who's counting during COVID, right?
Yeah. So Dr. Amanda Freed is a very distinguished doctor. She did her undergraduate from University of Michigan, Ann Arbor, and then she did her medical degree from David Geffen School of Medicine at University of California, Los Angeles. From there, she went on to do her internal medicine and peds residency at University of Washington. Internal medicine and peds residency at the prestigious Yale School of Medicine in New Haven, Connecticut. And from there on, she went on to do her medical genetics and genomics residency at University of Washington School of Medicine in Seattle. Like I said, since then, she's been working with us in the Department of Genetics in Southern California. She's the author of many peer-reviewed publications and has a lot of posters and presentations, both in adults and peds genetics. So we are very, very happy that she could join us and give us this lecture. Without further ado, I will have Amanda take over the presentation and present. Thank you so much.
Thank you so much for that introduction. Let's see if this is going to work. Okay, is everybody able to see my screen? Let me go, there we go.
Yep, you're good, Amanda.
Okay, great. So we're going to be talking about common genetic conditions that every primary care physician should know about. And we're mostly focusing on adults, but I'll talk a little bit about some relevancy in pediatrics as well. So these are our learning objectives for today. We're going to try to recognize the signs and symptoms of common genetic conditions in adulthood, review why some genetic conditions don't present until adulthood, and understand the importance of recognizing them for the management of the patient as well as their family members. These are the 5 conditions that we're going to be covering today. The first is hereditary thoracic aortic disease. The second is familial hypercholesterolemia. The third is hypertrophic obstructive cardiomyopathy. The fourth is Charcot-Marie-Tooth disease, which is also known as hereditary sensory motor neuropathy. And the last is Huntington's disease. And that's not an uncommon theme in adult genetics. I'd say the 3 primary domains that we see are cardiac, so these are all cardiac related, neurologic, and then of course hereditary cancer syndromes, which I think have been covered in another lecture. Okay, so to start off, we're going to be talking about irritable thoracic aortic disease, and largely this is divided into two groups, syndromic and non-syndromic. So in syndromic, these are the three most common conditions: Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome. We'll talk about Marfan syndrome in more depth in the next few slides, but the point is just that there are outward physical signs in each of these that there could be an internal problem with the thoracic aorta. And so you want to look for those signs and symptoms on the outside to know that there could be something going on the inside. Non-syndromic is much more difficult to recognize because there are no outward physical signs, and often the dilation of the aortic root is found incidentally, or if not found incidentally, it can present acutely with aortic dissection. But it's important to recognize that there is a risk to family members if that is the case. So when should you suspect Marfan syndrome? The main thing that should make you suspect it is dilation of the aortic root. So this is just a screen capture from an echocardiogram. This is the left ventricle here, the aortic valve here, and this is the aorta coming off of the left ventricle. And the dilation is here at the root of the aorta as it comes off of the left ventricle. And that can be measured, and based on the patient's size or height and weight, we can calculate a Z-score. That's easy to do online. And if it's greater than 2 standard deviations away from normal for the patient's height and weight, that would be considered dilated. And then in addition to that, you need some other factor. One of them could be ectopia lentis, which is seen here, where the lens within the eye is displaced. You shouldn't be able to see the bottom of the lens here, although that can be difficult to identify without an ophthalmologist slit lamp. It can be that you see aortic dilatation and you have a mutation in the gene that causes Marfan called fibrillin-1, although we don't always have access to genetic testing. And so what is most commonly the way that we diagnose Marfan syndrome is this last or third and last option, which is dilation of the aortic root and a systemic score greater than 7 points. And we'll cover that in the next slide, but basically the systemic score are those outward physical signs that I was talking about earlier. So this is the systemic score, or pictures of what we look for in the systemic score. You can find the actual systemic score online through the Marfan Foundation. It's a pretty simple 20-point scale, and if you get greater than or equal to 7 points, that would be concerning for Marfan syndrome. So among the things that we look for first are the characteristic facial features. You tend to see this very long, thin face with down slanting of the eyes, often a retrognathic chin, and maybe a smaller jaw. On the body, we can see abnormalities of the chest wall. It can either point out or point in or be asymmetric. We often see reduced elbow extension. You can see flat feet, or if you look posteriorly, you'll see ankle insufficiency here. And then you'll see long, thin fingers. And the way that we sort of formally evaluate whether the fingers are long are these two signs called the wrist and the thumb sign. The wrist sign, you ask the patient to wrap their thumb and their fifth finger around their wrist. And if the two nails overlap, that would be positive. If they don't overlap or don't touch at all, that would not count. And then in the thumb sign, you ask the patient to fold their thumb over their palm and then their fingers over their thumb. And if their thumbnail sticks out entirely, you can see the entire thumbnail, that would also count as long fingers. The formal term for that is arachnodactyly. There are a few more things on that systemic score as well, but these are the most common that we see and the most easily examined from the outside. So we frequently get referrals for one or two of these things oftentimes in young males who are maybe tall and a little bit thin, and perhaps they have one of these and some asymmetry of the chest wall. It's very rare though that somebody actually has Marfan syndrome. So of people, for example, with a chest wall deformity, less than 1% are actually going to have Marfan syndrome. So a chest wall deformity is common, but if you see it together with several of these other things, that is when you should suspect Marfan syndrome and ask about a family history of aortic dissection. So non-syndromic, where there's no outward physical signs, there can still be aortic aneurysm and ultimately dissection. There have been over a dozen genes that are associated with isolated non-syndromic thoracic aortic aneurysm. The most common gene is this gene here, ACTA2, but the actual gene doesn't matter. The point is that there's an increased risk of dissection in that person and perhaps in their family members. So up to 20% of people who have a thoracic aortic aneurysm have a family history of thoracic aortic aneurysm. And so it's important to ask about that family history, and if present, try to evaluate for aortic aneurysm before it proceeds to dissection. And the reason that the genetic testing itself is actually often not that helpful is that we actually only find a genetic change in about 30% of these families. But in the other 70%, there's still a risk. We just don't know what the gene is. So how is this inherited? It's inherited in what is called an autosomal dominant pattern, meaning it gets passed down from generation to generation. And there is a 1 in 2 chance for an affected person for their child to be affected. So you'll see that roughly half of their children will be affected, but that's not a perfect rule. You can imagine that if you flip a coin 5 times, you could theoretically get 5 heads in a row or 5 tails in a row. And so sometimes it's not a perfect 50%. But if somebody does not inherit it, like this family member here, there's no risk for their children. If somebody does inherit it, then there is a risk for their children to be affected. So why do you need to know about this condition? The most important thing is to ask about it in the family history, or if your patient is the one who has the aneurysm, to know that their first-degree relatives, their siblings, their children, their parents need to be evaluated for this. I would generally recommend an eye exam for these patients, especially if you think it could be Marfan syndrome or one of those other syndromic conditions, because there can be several different eye manifestations, although the most common is that lens dislocation that I showed earlier. You want to avoid things that could cause that aortic aneurysm to rupture. So trauma and like high impact sports, or things that can increase the intrathoracic pressure, such as scuba diving, skydiving, roller coasters, those types of things. It's important if there is aortic dilation that you manage hypertension aggressively with ACE inhibitors or beta blockers to reduce the pressure on the aorta so that hopefully it does not progress to dissection. And you want to have regular cardiac imaging to monitor the size of the aortic root and whether or not there's a need for surgical intervention. And then it's also important to recognize dissection if that is how it presents. Oftentimes the presenting sign will be, or symptom will be chest pain, which can be mistaken for an MI, and they're treated very differently. The main thing to avoid is antiplatelet therapy, which is often given when a myocardial infarction is suspected, but can be devastating if there is instead a dissection. Oftentimes, the quality of the chest pain will be described as a ripping or tearing sensation. It can be more in the upper back than in the chest. And you may appreciate faint pulses, especially in the lower extremities. And this needs urgent surgical intervention. Okay, so moving on to condition number 2, familial hypercholesterolemia. This condition causes severely elevated LDL levels. So that's one type of cholesterol, the quote unquote bad cholesterol. You can also see elevations in total cholesterol as well. Generally speaking, you'll see an LDL over 190 and a total cholesterol over 310. There are currently 3 genes that we know of that are related to this condition, although there are likely more out there. And this is quite common. We think that the incidence is about 1 in 200 to 1 in 250. In terms of outward physical signs that you may see the accumulation of cholesterol under the skin or on tendons. So the Achilles tendon is one place. You can also see it in other tendons like the patella. And then it can collect under the skin as well. And the thin skin under the eye is a place that around the eye is a place that you can readily see it. These are the formal diagnostic criteria. There's actually several different calculators for this. This is the Dutch criteria. I believe the UK has another kind of algorithm to diagnose this, and then the American Heart Association has one as well, which is the most straightforward of them. But I wanted to use the Dutch criteria to illustrate some of the things that you would want to look for on exam or ask about on family history. So on family history, you would want to know if there's premature coronary or vascular disease. So early heart attacks or early strokes, that is less than 50 in a male or less than 60 in a female, or a family history of just high cholesterol. This can actually present in childhood. So children can have high cholesterol even in their teenage years. On exam, in addition to the collection of cholesterol in the tendon that we saw on the last slide, you can also see this eye finding called arcus cornealis. And this is one that you do not need a slit lamp for. You can see this with the naked eye. And it's an accumulation of lipids in the eye that causes this lighter ring around the outside of the iris. And this is common in all of us with age, but in familial hypercholesterolemia, you'll see this develop at a younger age. So if you see this lipid accumulation in somebody under 45 years of age, that would be indicative of this genetic condition, familial hypercholesterolemia. Of course, the diagnostic criteria also incorporates the lipid level, if DNA analysis is available, and you add up all the points in your patient, and this is how you score it. This is inherited in sort of a little bit more of a complicated pattern that is sometimes called semi-dominant. So it is passed down from generation to generation. And if you only have one genetic change, you will develop high cholesterol later in life, in your teenage years or adulthood years. But if both parents have high cholesterol and a child inherits two genetic changes, they can develop high cholesterol at a very, very young age. Sometimes we see it as young as 2 years old. And they are at risk for developing coronary artery disease at very young ages, like in their teens or 20s. So that's why it's important to ask about the family history and screen children at a young age if there is a family history of high cholesterol. So why do you need to know about this? A couple of things. One is that it's really important. This is something that is manageable. And so it's important to manage it aggressively with statin medications or other lipid lowering medications. If this goes untreated, men have a risk of heart attack by age 50 of 50%, and women have a 30% risk by age 60. And I think one thing that's really important to know is that diet and exercise alone for these patients is not going to be sufficient. It's not a failure of the patient. It's not that they aren't dieting enough or exercising enough. This is something that they were born with, and they are never going to be able to achieve normal lipid levels without medications. So the goal is to bring down their cholesterol levels quickly. And oftentimes that will require even more than just one medication. So we start them on a high intensity statin, and we want to bring their cholesterol down by 50% within the first 6 months. And if you're not at that goal, you want to add on a second medication. And then, like we were talking about on the last slide, another reason that this is important is that if both parents have high cholesterol, their children can have severe and early manifestations, including coronary artery disease by their mid-20s. And like I said, their cholesterol level may be elevated as young as 2 years old. And as they get older, their lipid levels can reach over 500. So currently the screening that is recommended by the American Academy of Pediatrics in the US is for all children, if there is a family history of cholesterol, to be screened at 2 years of age. If there's no family history of high cholesterol, or at least no known family history, screening is recommended at ages 9 and 10. And then again, in the later teenage years, like 17 or 18, because you want to catch this early and treat it aggressively before they have the chance to develop coronary artery disease. Okay, so moving right along, we're going to get to condition number 3, which is hypertrophic obstructive cardiomyopathy. There are several different kinds of cardiomyopathy that can be hereditary, but perhaps the most scary, or the one that keeps me up at night certainly, is this condition called hypertrophic obstructive cardiomyopathy. And what we see in this condition is hypertrophy of the left ventricle with a wall thickness greater than 15 millimeters. And specifically, what you tend to see is that thickness is in the septum between the right and left ventricles, and that is near the left ventricular outflow tract. And sometimes this hypertrophy can get so large that it obstructs the outflow tract, hence the name obstructive cardiomyopathy. The symptoms can include shortness of breath, fatigue, chest pain, palpitations, feeling lightheaded or syncope. And these symptoms are often worse with exertion or dehydration. On exam, what you'll hear is a harsh crescendo, decrescendo systolic murmur at the left lower sternal border. That's the sound of the blood trying to get past this obstruction. What will decrease the murmur is if you increase the amount of blood coming into the left ventricle, so increasing preload by squatting. And if you do that, you can overcome this obstruction, and that will decrease the murmur. Or the other thing that you can do is to have the patient Valsalva, essentially bear down as if they're having a bowel movement. That will decrease the amount of blood that is returning from the body to the heart. That will make the obstruction worse and the murmur will get louder. So those are easy ways to identify this murmur or this condition before you even have an echocardiogram. So the inheritance pattern here is also dominant, meaning it gets passed down from generation to generation. If somebody has it, there is a 50% chance that they pass it on in each pregnancy. But there is what we call decreased penetrance, meaning not everybody will actually develop the hypertrophy, or it may be very mild. So what you may see, and it also tends to be worse in males than females. So what you may see is a sort of remote family history of perhaps sudden cardiac death, and then people who are more mildly affected. And a male can inherit it from a female who doesn't necessarily have significant hypertrophy, but it can be much more significant in that woman's son. So why do you need to know about this? Well, for one thing, it's common. We think that the incidence is about 1 in 500. Like I talked about, there's variable penetrance. So there may not be a family history in a first degree relative, like a parent, but there may be a more remote family history in cousins or aunts and uncles. And so it's important to take that family history and know if your patient is at risk. This sadly can present with sudden cardiac arrest, especially in young athletes. So if you hear stories about often teenage boys collapsing during some sort of sports practice or game, that is often due to hypertrophic cardiomyopathy. And so it's important, if there is that family history, to identify at-risk members earlier. So if you have a child presenting for their sort of routine checkup, and they are particularly active in sports, it's important to ask if there's any history of heart problems in the family, and do those exam maneuvers to look for any signs that there could be hypertrophic cardiomyopathy. Now, if you're taking care of older patients, adults, and your patient has hypertrophy, even if it's, perhaps mild, they're older, there's no history of sudden cardiac death, still important for their children to be examined, because like we said, it could be relatively mild in a parent, and then their child can present with sudden cardiac arrest, which is, of course, devastating. I'm hearing some, I don't know if there's a question, if I should stop or keep going. Let me look at the chat.
I think just go on. We will address the questions at the end.
Okay,
Maybe
thank you.
somebody got off mute. Thank you.
Okay, so now we're moving more into the neurologic realm. So we'll be talking about this condition called Charcot-Marie-Tooth disease. This was named after 3 different people. We're trying to get away from naming things after people. So now we're trying to call it hereditary sensory motor neuropathy, although that is a bit of a mouthful too. So it hasn't quite caught on. You can see different patterns of the neuropathy if you do nerve conduction studies, although it doesn't really matter one way or another. This condition can have onset in either childhood or adulthood. So you can see kids who develop symptoms, but oftentimes it is not until adulthood that people begin noticing the signs and symptoms of the neuropathy. And on exam, what you'll see is this characteristic upside down champagne bottle look of the leg, the lower leg. And so what's happening here is that the nerve conduction is not strong down the leg, and so the muscles start to atrophy, particularly around the ankle. And because of that, the tendons that come down into the feet start to contract, and that pulls back on the toes. And so you get these hammer toes and very high arches in the feet here, which can be very debilitating. It's not a life-threatening condition, and there's not really much that we can do for it other than supportive therapy. But it can be quite uncomfortable and interfere with gait and walking. This is a very heterogeneous condition. There have been over 80 genes associated with Charcot-Marie-Tooth disease. The inheritance pattern, there can be 3 different inheritance patterns. So the most common is dominant, which we've already talked about several times today, so I won't go over it again. But we can also see X-linked and recessive. So what that means, this is a pattern of X-linked, meaning the gene is on the X chromosome. Men always inherit their X chromosome from their mothers because they're getting their Y chromosomes from their fathers. And because women have 2 X chromosomes, they're often unaffected, but then they can have an affected son. So you'll typically see this pattern of a female carrier with an affected son and an affected father. You will, if it's X-linked, you'll never see male to male transition because, again, males are transmitting their Y chromosome to their sons, not their X chromosome. And then you can see a recessive pattern in this condition as well, meaning both parents are carriers and then their children can be affected. So carriers are expected not to be affected. They are completely asymptomatic. They have a second copy of the gene that is working, but when a child inherits both of the not working copies, one from each parent, that's when they are affected. And so you expect for each child of a couple where both are carriers, a 1 in 4 chance for their child to be affected. So if you have a large family with several children, you would expect roughly 25% of the children to be affected, although again, it doesn't always work out perfectly. And there's no male or female predominance. So both the males and the females in that family are at risk for having the condition. This condition is just very common. So it's important to know about. We think that there's a prevalence of about 150,000 in the US, which is more common than, for example, Down syndrome. And again, there isn't much to do in terms of treatment other than just, supportive therapy with canes or walkers or wheelchairs. But what you can do is take a family history and try to let them know what the chances of this happening again for future family members. Okay, this is the last condition, and then hopefully we'll have a lot of time for questions. Again, also in the neurological realm, this condition is called Huntington's disease. This is a progressive neurologic disorder that causes both including motor, cognitive, and psychiatric disturbances. Typically, onset is not until adulthood, between 35 to 45 years of age. And once symptoms begin, there is a long progressive decline over the next 15 to 20 years or so. Oftentimes, the first thing that you'll see is actually what I tend to see is psychiatric, just anxiety or depression. But then you can start to see these chorea, which are these involuntary writhing-like movements. And oftentimes the first presentations almost look like a tic, or the patients will try to almost obscure them by if their arm moves uncontrollably, then they'll touch their hair or adjust their shirt or something to try to disguise it. But then after the chorea starts, they start having more motor impairment, difficulty walking, and ultimately it progresses into a cognitive impairment or dementia type of condition. It is very debilitating and a very, very sad condition. What's happening here is this is a condition where the part of the gene actually gets longer. And so this would be a normal protein. This is the abnormal protein that is lengthened. It's abnormally long. And that abnormally long section causes it to not break down and to actually gather and aggregate. And that ultimately causes cell death in the basal ganglia. And so this is a normal brain. This is a section of brain from somebody with Huntington's disease. And this section that you see is essentially missing is the basal ganglia, which controls movement. And you have overall atrophy as well. This inheritance pattern is also autosomal dominant, but what we see is a phenomenon called anticipation, where you tend to get younger and younger onset as you go on to with the generations, and eventually it can even become juvenile onset. This is the pedigree for a different condition that tends to have more repeats, so it doesn't quite ever get this long. These are the numbers here, like the length of that part of the gene. But it's just important to recognize that there is a risk for their children, and in their children, it can have a younger age of onset, and theoretically, even in childhood, we can see it if it gets very long. Okay, and with that, we'll take questions, and this is my dog, just because I like to have something cute to look at while we discuss things.
Lovely. Thank you so much, Dr. Freed. This was lovely. It's quite comprehensive. And so I'm really hoping that we will get some really good questions in the chat. But before we delve into the questions from everybody else, I'm going to take this privileged opportunity to ask a question myself.
Sure.
So my common finding is, or observation is, that a lot of times primary care providers will see individuals that are on more obese end, weight-wise and BMI-wise, and it would then be correlated with a hypertrophy of the heart. And the doctors would then just say, there's this obesity, this is why there's a hypertrophy. And then possibly ignore the family history and tendency to refer to genetics. And I was wondering if there's anything that you think could, that the PCP or the cardiologist could ask that could then defer them to thinking, okay, this may be hereditary.
Yeah, so certainly you want to ask about any family history of sudden cardiac death, because that would be concerning for not just run-of-the-mill hypertrophy due to often hypertension. So that would be the first thing that I would recommend. The second thing is that there are certain signs on the echocardiogram that will make you think of hypertrophic obstructive cardiomyopathy. So one is when it's more related to high blood pressure or just, obesity, old age, those types of things, you'll tend to see a more equally uniform hypertrophy, often called concentric hypertrophy on the echocardiogram, whereas in hypertrophic cardiomyopathy due to a hereditary cause, you'll tend to see this septal or apical predominance of the hypertrophy. So that should definitely clue you in to it being a genetic cause. It's not a perfect rule, but that is definitely more suspicious than just regular concentric hypertrophy.
That's very helpful. Thank you. Now I have some questions from the audience members. So let's see.
Sure.
The first question is from Sayed Mohammed, and they're interested in finding out what medical disorders can result in high cholesterol levels. I'm thinking they're trying to say if there are any other hereditary causes for high cholesterol besides the ones that we discussed.
Yeah, so certainly just having metabolic derangement, so diabetes is going to often also include high cholesterol, obesity, as you already mentioned. But in familial hypercholesterolemia, it's typically even higher than you would expect in general, patients with metabolic syndrome, diabetes, obesity, etc. And it tends to be at a much earlier age. And you'll often find that family history of early coronary artery disease as well. And so that's, like I said, why we recommend screening even in children before they've developed diabetes. Because if it is a hereditary, a familial hypercholesterolemia, you will see it even in childhood. But you're right, type 2 diabetes it's not genetic in the sense that there's one particular gene that causes it, but we certainly do see that it's hereditary, it runs in families. There are almost certainly genetic predispositions out there that we have not really understood yet. And then it also comes down to that question of, nature versus nurture. You share your genes with your family, but you also share your environment and your diet. And so you actually see that type 2 diabetes does tend to run in families, even though it's not a specific gene that we know that causes it.
Mm-hmm. Yeah, and we call that a multifactorial hereditary condition where it's not a single gene, but multiple genes that are causing the concerns.
Exactly, yeah.
And so the next question is also from Sayed Mohammed, and they wanted to know if there are any gastrointestinal problems that you notice with Charcot-Marie-Tooth.
Not typically. It is typically isolated to the peripheral nerves. I'm sure that, just generally functional abdominal pain, constipation are just common things. So perhaps that is a little bit more common in Charcot-Marie-Tooth, but generally it is an isolated neuropathy that primarily affects the peripheral nerves, the hands and feet most, the feet worse than the hands. It is quite painful, and a lot of pain medications do cause constipation. So if they're on any pain medications that can affect the GI tract, it would be important to manage that appropriately.
Mm-hmm. Yeah, the next question I have is from Rizwan, and I wanted to clarify the question. I'm not entirely sure if I'm getting it correctly, but they're asking what testing is available for screening. And I'm not sure if this is like a broad question, like can everybody get a test and figure out if they have any of these hereditary conditions, or if there is anything in particular about each one of these that can be tested, I guess. So like sort of a broad question, but I was wondering what your thoughts are on both narrow version of the question, the broad version of the question.
Yeah, so I tried to go over some screening for all of these. So for example, checking cholesterol levels in kids, for hypertrophic cardiomyopathy, doing a good physical exam, especially in young adolescents who are active in sports. You want to make sure that you are doing a thorough cardiac exam, listening for murmurs, and also doing the preload and afterload testing, the squatting and the Valsalva maneuver to really make sure that you're getting a good physical exam on that. For the aortic conditions, it would really be an echocardiogram in all first degree relatives if there's a family history of of thoracic aortic aneurysm or dissection.
Mhm.
In terms of like genetic testing and genetic screening, we don't currently do any sort of routine screening on everyone.
Mhm.
Although I think that as genetic testing gets more common and less expensive, we will probably be going to that in the future, especially for these really common diseases like familial hypercholesterolemia and hypertrophic cardiomyopathy.
Mhm.
But that is not something that is currently recommended by the American College of Medical Genetics.
Mhm. So one case that comes to my mind that I recently saw in Pakistan with actually Dr. Ahmed, that was very interesting because we saw a child with with homozygous mutations in one of these genes that I can't even remember which one was. I want to say it was APOB, but I could be wrong. But essentially, there was a homozygous mutation because of the high rates of consanguinity in Pakistan. And so, one question that comes up quite often in our genetic counseling sessions in pediatric setting is, could I have done something to have circumvented this condition in my child? And obviously we would say, this is not something that you did or you caused, or, there's nothing that you could have done during or after the pregnancy that could have altered the course. But one thing that we have been discussing is potential premarital screenings for individuals that are consanguineous. And so this was probably the answer that Dr. Rizwan may want to consider is, when you're talking to your family members that you're talking to and they have autosomal recessive known diagnosis in a child, then perhaps screening for other at-risk relatives. So if there is a mother of a child and she has a sister who's also interested in getting married to another first cousin or a second cousin, then perhaps those screening tests could be potentially available for those individuals.
Yeah, so what you're talking about is carrier screening. And what some people choose to do, especially if there is a consanguineous marriage, is what we call expanded carrier screening, which is looking broadly for many different autosomal recessive conditions. And if that is available, that can certainly help identify a risk. The good news about ApoB and the hypercholesterolemia is that it's actually quite treatable. So especially if you recognize it early, you identify the high cholesterol, you get them started on medications, and you monitor and make sure that you're keeping the lipid levels low, you can hopefully avoid, the most serious effects of the condition. But there are many autosomal recessive conditions that are not treatable and can be very devastating. And so, trying to identify that and avoid that whenever possible is certainly helpful for the family to avoid going through a really tragic situation. But even here in the US, not all couples do expanded carrier screening.
Yeah, we have, I guess, a difference in perspective, because obviously, the probability of finding two variants in the same gene in individuals that are non-consanguineous are so small that most people would say, yeah, we're not related at all. There's no chance that we're going to have the same genetic alterations, or at least in the same gene, so we can forego that. However, that isn't the case in Pakistan. Obviously, with 70% consanguinity, there tend to be a lot higher likelihood of finding individuals that would have similar genetic alterations. And so there's a long ways to go in Pakistan in terms of genetic testing and the availability of newborn screenings and expanded carrier screenings, but this is a good place to start talking about what conditions are there that are highly prevalent, and then to at least start off with some sort of a carrier screening specific to the population that that we're talking about. So that there's more to come on that. That will lead me to my next question, which is going back to Dr. Ahmed, and he is asking, what is the utility of doing genetic testing in families with hyperlipidemia? What are your thoughts on that?
So I think you just highlighted the importance of the genetic testing. It's really to identify at-risk family members and whether children are at risk, particularly for being homozygous. In terms of treatment, it does not make a significant difference whether it is in, ApoB or LDLR. And to be honest, we often don't do genetic testing. The importance is really to recognize that this is something that is genetic, and it's not just related to diet and lifestyle. And so sometimes I have done genetic testing in patients who are really in denial about that and think that if they just diet and exercise hard enough, they will be able to control it, and are really resistant to taking medications. Sometimes, unfortunately, showing it to them in black and white, this is the change in the gene that is causing your high cholesterol, and that can sometimes persuade them to take the medication. But otherwise, I think the actual genetic testing is primarily helpful for reproductive decision making and identifying at-risk family members, and not necessarily for management of your patient.
If I may, the reason I asked the question was, as far as treatment is concerned, in the case that Aisha was alluding to that we saw at NICH, this kid had a cholesterol level of greater than 400, and they were treating the child with, first and second generation statins, and they couldn't get it lower. So the question is, if you have a person who actually has a genetic reason for their hypercholesterolemia and not lack of exercise or diet or other environmental factors, do they treat them in the same manner as they would treat any other person with hypercholesterolemia? Or if you have a genetic reason for that and significantly higher levels, then you straight away go to some big guns and use, say, third generation statins, or you can do plasmapheresis or things like that. So does it make a difference in those patients?
Yeah, so you're right. So particularly in people who are homozygous, you may need to go to plasmapheresis, which is essentially just filtering the cholesterol out of the blood. But the guidelines for familial hypercholesterolemia, which you can make a diagnosis with or without genetic testing, say that you should start immediately with a high intensity statin. So don't start with a low intensity statin, although I'm not sure if that is necessarily true for kids. I would have to look that up. And then again, if you're not at your goal within 6 months, to add a second agent immediately. And then sometimes what I see here, especially at other places, is that there's a new medication called PCSK9 inhibitors, which are more expensive and often, depending on insurance, can be restricted. And so if you have a genetic test that shows that you have a genetic cause, that can often facilitate the use of PCSK9 inhibitors, although that's really more of an insurance issue than, what is the appropriate management. The appropriate management is to add a second line medication if you're not at goal within 6 months. And again, the goal is to get your LDL down by 50% or less than 100.
Thank you.
Awesome, thanks. And the next question / comment is from Dr. Saadat Ali. So Dr. Saadat is actually a laboratory specialist who is working with one of the labs in Pakistan, trying to start up some genetic testing availability in Pakistan. And their comment is very important and pertinent to this conversation, where they're suggesting that it would be helpful if anyone can share the list of most common genetic disorders in Pakistan. That would have to be a huge undertaking to, first of all, figure out, based on consensus, paperwork, literature review, et cetera, but it's a really good thought and really good suggestion that somebody ought to start off taking some notes on what are some common genetic conditions in Pakistan.
Yeah, and I tried to put the incidence in for a lot of these, and I apologize. I did look to try to find what the incidence was for these conditions in Pakistan and could not find that data. So I just put in the US numbers just for perspective, but I agree that I don't think that we necessarily know what the incidence of these is. So I did say, my title of the talk was common, but I don't know how common these are.
Yeah.
And it certainly, some of them do vary based on ethnicity. Huntington disease in particular, we see more in certain parts of the world than others, but I'm not sure what the incidence of that is in Pakistan.
Right, exactly. And I think that's where we're lacking a lot of insight into the population, is because we don't have good data on the incidence, because obviously the diagnosis, because these are underdiagnosed conditions, are often they remain undiagnosed. I mean, obviously, Huntington disease is hard to miss, but other more subtle conditions, like if a family member dies of a sudden heart attack, no one really knows if that was because of a hereditary thoracic aortic disease or like some other myocardial infarction that could have caused the problem. So those are undiagnosed or super really underdiagnosed conditions. And so yeah, long ways to go in some of the emerging countries.
Yeah, well, I mean, that's a challenge that we deal with here. I mean, the term heart attack is actually quite vague. And I think to most of us in the medical community, when we say that, we mean a myocardial infarction, but to a lot of lay people, that could equally mean sudden cardiac arrest from hypertrophic cardiomyopathy, or an MI from familial hypercholesterolemia, or an aortic dissection. And so that when you get such a vague family history and you don't have any records, it's extremely challenging, because all three of those could be on your differential diagnosis.
Yeah, right, exactly. Yep. And so that's why we always want to know as much as we possibly can, ask about all the possible ages and all the other environmental factors that could have been at play. And so we do try to do a lot of this investigative and method of deductions, but there's only so much you can do with family history. And so that's why we are starting to, at least at NICH, starting to take notes and to take detailed pedigrees, and to at least try to start a small database of our own. But it is a massive endeavor, and so we're definitely, there's a lot of work to be done. So with that, I want to say thank you so much, Dr. Freed. This was a lovely talk. I really enjoyed the talk, and I really even more so enjoyed the conversation after. And so thank you so much for taking the time out on your busy Sunday to talk to us, on your holiday Sunday, I should say. So I appreciate that, and want to wish you a very happy long weekend and happy Thanksgiving, but although it's a little late. But for the audience members, please take the time to take the survey. Like Dr. Ajaz said earlier, this is our only way of finding out what what you guys want to see next. This is our last lecture in the lecture series. Next year, we are planning on doing more of a conference style, where we will be requesting a submission of a small abstract, and we will be putting it together as like a mini conference every month or every other month, if not every quarter. So we're really excited about that. Next year, we have big plans for the PSMG. We're planning on opening up the forum for membership and collecting more and more data and moving forward with some of the things that we talked about today here with Dr. Freed. So with that, I want to say thank you very much for the organizers, and great thank you for joining us today. I appreciate it all. So have a good night to those of us in Pakistan, and happy Sunday to those of us here in the US.
Thank you so much for having me.
Have a good one. Bye-bye.
Bye.